On today's podcast, we're talking all things glaucoma. What are you doing in your practice to prep your patient to be able to understand what it means to have glaucoma? Are you partnering as an optometrist with an ophthalmologist to make sure that patient journey is on point, to make sure they feel safe and secure whenever you have that transfer of trust? Are you educating them about Migs, SLT, glaucoma drops? Are you still old school in saying that we're going to use drops for everything? Well, on today's podcast, we have an expert from the one and only Duke in my backyard, Dr. Sam Barsam. Friends and family, welcome to Defocus Media, Optometry's #1 podcast. Let's go. This is a Defocus Media production. Audio Jungle. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, Optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover. Super excited today because we have an expert in glaucoma, someone that has all the answers that's going to help make us better clinicians, whether you're an optometrist, whether you're an ophthalmologist, whether you're just getting in the game. I hope you got your pens and pads out because we're about to put you on the game. Friends and family, I'd like to welcome my colleague, Dr. Alexander Barsam. How are you doing today, my friend?
Hey, doing great, Taylor. How are you today?
I'm doing fantastic, man, and I'm super excited to have you on the show today. I actually was able to catch one of your CEs last year, and I think it might have been over at our Briar Creek.
Yeah, absolutely.
Yeah, my office is not too far from there. Literally, I can walk.
Oh, you can walk there,
right?
Yeah, very nice, very nice. It's bright and early there too. So
right. Yeah. Well, I'm a morning person, man. I'm up every morning around 4:35 a.m. You know. So
you beat me. I'm a 6 a.m. riser. Okay, I got something to strive to. But yes, thank you for the nice introduction, and I'm very excited to be here today as well.
Yeah, well, let's get to know you a little bit better, my friend. If you don't mind, maybe sharing a little bit about your story, your journey. You know, how did you get into this wonderful world of healthcare, eye care? Tell us a little bit about your schooling. And we also like a fun fact, man. We love to get those little fun facts that we can talk about and speak to the whole world, my friend.
Yeah. We'll save the fun, juicy facts for at the end of this. But yeah, so I grew up in St. Louis, Missouri. So that was a fun place to grow up in the Midwest. You know, not close to any oceans or any mountains, but moved away to USC for college on the West Coast. Originally thought I was going to be a business major, but quickly made the switch to the pre-med track and then did my medical training down at the University of Miami, Florida. Throughout most of the time, I thought I was like, I love cardiology. I want to do internal medicine, and then had an ophthalmology attending kind of take a week or two to be like, hey, you know, that physiology you love in cardiology, I can get your fix in ophthalmology. And she really convinced me to go to the dark side and join, eye care, and, ended up doing residency at St. Louis University and did 4 years there. And I was pretty undecided throughout all of residency. I loved everything. I was like, first year I want to do retina. And then I was like, I want to do cornea. And then maybe I'll do glaucoma. And I couldn't really decide. I had a mentor, Susan Cullican, reach out to me once, and she's like, I have this really cool opportunity. It's called the Chief of Ophthalmic Trauma year at WashU. So what do you think? Since you're undecided, it's an attending job. It's a good teaching role. And I was like, you know what? Let's do it. Like, what's
nice?
Another year in academics. And so I spent a year at WashU in St. Louis doing all the trauma that came into the hospital, all the inpatient consults, did a lot of resident training as far as cataract surgery. And then I stayed on there for a year as assistant professor in comprehensive ophthalmology. So comprehensive ophthalmologist, not formally fellowship trained in glaucoma, but I really grew my interest in glaucoma there when I was working at the VA there, which was a great opportunity to learn Migs from some mentors there. And then about 2 years now, wow, time flies. We moved down to North Carolina. My fiance and I, we wanted to kind of be in an area that was a little closer to the coast, the mountains, and have some good outdoor activities. And I was lucky enough to take a job at North Carolina Eye, Nose, and Throat. And for the past couple of years, I've been growing my practice. So to answer the fun fact, so, between jobs, we took a month off. So that was kind of the unique opportunity to take some time and travel. And We went to Australia for a month. Did some.
Wow.
I really love snorkeling. It's one of my hobbies. Snorkeled a few cool reefs, and one of the reefs we went out to was in the northwest part of Australia. It's crazy. It's like the size of the United States. It's where the desert meets the ocean. We got on this boat. They give you wetsuits. About 5 minutes out, they're like, "All right, we're gonna do some snorkeling. Hop in." And then like you put on your snorkel, you open your eyes, and it's two huge whale sharks right there. And
Oh,
so
wow.
successfully swam with the two largest mammals in the world, and that's my cool fact. Yeah.
Wow. Wow. You know, it's funny. My wife and I, we went on our honeymoon, and I think we were in Morea, and we had a water bungalow, and I remember seeing all the fish in the water, and they were
Yeah.
big, colorful, and my wife was just jumping in the water, and I was just like, "There's
Yeah.
no way in hell I'm
There's
going
no
to
way.
do that."
Yeah.
But then she finally got me to do some wild stuff, Dr. Barsam. She told me that we're going to go swimming with the sharks. And
Yes.
I was like, no, I'm not going to go swimming with the sharks. She said, yes,
Yeah.
we are. So, you know, she smiled at me. She worked her charm. And I was like, oh, hell, I'm going to swim with the sharks.
Yeah.
We get out there. We're swimming with the sharks on the board with our guide. And the guy had a strong accent. And he could tell I was terrified. He could tell I was, you know, just shaking literally, you know. And,
Yeah.
you know, we get out to the middle and we start seeing all the kids playing around with the sharks swimming around and they're not doing anything. And then he looks closer to me and he comes up to me. And it was this Caucasian man, older guy, and he was hilarious as hell. And he said, sir, these sharks, you know what they like? I said, no, tell me. He said, they like to eat black people. I said, oh my goodness, man. Scared the hell out of me. So,
Yeah.
you know, I
Oh my
have
goodness.
never said that I will swim with sharks ever again because it made me nervous as hell. I will
Yeah.
swim on the side of the beach and watch everyone else do that, my friend.
But you
So,
survived, and you're braver and stronger now. And
yeah,
look
but
at you.
never again,
Yeah.
never again.
Never again. Never again.
Never again,
Yeah.
never again. But no, I love that,
Oh,
man. That's
that's
awesome,
amazing.
man. And welcome to North Carolina. You got to love this state, especially the Triangle area where we're at, because to your point, 2.5 hours from the mountains, 2.5 hours from the beach.
Yeah.
You got the best of both worlds here, and you got
Yeah.
beautiful people, highly diverse. And the one thing that I love is the healthcare that's in this area. We have some of the best physicians in the world here.
We really
You
do.
know, whether it's optometrists, whether it's ophthalmologists, whether it's primary care physician, whatever it may be, we have the best of the best here. And that's why we're having this conversation today, man. And I really want to dive deep into glaucoma because one thing I've noticed in my practice is that there's a lot of glaucoma in the triangle. And I'm actually blown away by the amount that I see walk through my doors. So I'd love to just, you know, maybe just get into, you know, what the patient journey looks like from your perspective as an ophthalmologist. I know my office, what it looks like, but I'm curious to know what you experience when we hand off or transfer over a patient into your care. What takes place? What kind of conversations are had? How do you set that patient up for success? And let's take it from the my friend.
Yeah, absolutely. I mean, to echo your point, I mean, yeah, we're way booked with glaucoma patients. And that's only going to get worse. I feel like they're expected to double by 2035 with our baby boomers. But, you know, I look back to when I was training 2016 to 2020, as you said, it's like, let's put you on drops and let's, oh, you're not well controlled. Let's add more drops. And then you get to this point where you're like, man, we've been progressing on our fields, our OCT, and I think you need surgery. And then our main options were, you know, tubes and trabs, some more, you know, high risk, high reward surgeries. And so there's this kind of chasm that was there that, you know, these patients that are not being, you know, intervened on earlier because of the risk of these larger surgeries. And what I've, you know, really noticed in my, you know, handful of years in practice is the trend towards a more interventional approach or an early, more proactive approach.
Okay.
So I think about like, you know, how do we even get there? Why were drops such a, you know, what were such a foundation? I mean, really the technology and the safety and efficacy of drops exploded in the 80s and 90s, and the surgery stayed about the same. And so, you know, drops really took a charge. And then it's really only been in the last 10 years where I feel like the majority of the glaucoma field can say that there's a lot of other surgeries that are being added to the armamentarium that can find that nice sweet spot of good efficacy and good safety profile that allows us to justify intervening earlier on in the disease process. So really, you know, when I meet a glaucoma patient, I'm thinking about the initial challenges that we had with patients on a lot of medications. You know, big one is obviously adherence. Are they administering the drop right? I can think of when I go to the dentist, I'm all of a sudden flossing a couple weeks before the visit. They can tell right away that this guy's he's kind of full of it. He has not been flossing the past 6 months. We can't really tell as when they're doing their field or on their OCT, those don't lie. But I mean, if they take their drops, a couple of days before the visit, they're gonna look pretty well controlled. And I think that that's certainly a big hurdle that we're all dealing with. When you think about compliance, back in the 80s, it was pilocarpine dose 3 to 4 times a day. All right. And the studies showed at that time, your compliance rate's about 68, 70%. Fast forward to now, at nighttime Zolatan use, what's your compliance rate? You'd think it'd be better, right? It's the same. It's about 70%. So we have not really moved the needle much, as eye care providers and motivating our patients to take medications. And I think that's just the nature of the disease, right? Like it's a silent disease similar to diabetes. You don't really feel the damaging sequelae, but they feel the drops. I mean, they sting, they burn, they look in the mirror, their eyes are red. So it's a constant reminder of, hey, you have glaucoma, so there's some negative effects from that. And so I really try to address kind of those challenges or those barriers that patients are having, when they come in the door. And so I'd say that's where I'd start, is kind of where are you with your medications, and trying to say, can we improve your quality of life by getting you off some of these medications and not waiting until we're in the later stage of disease to intervene.
I love that. And I just love the fact that you actually sit down and have a conversation and think about their lifestyle, right?
Yeah.
Because when you think about glaucoma medications, especially prostaglandins, and you think about the impact they have on the ocular surface, and you think about the world we live in, when we look at digital devices, we don't blink enough, and that dries the eyes out. I mean, we're already setting ourselves up for that perfect recipe for disaster. And if you add, glaucoma medications on top of that, it's going to be a hot ass mess before you know it, right?
Totally.
So to be able to have someone that's sitting in front of you, that's actually listening to, your lifestyle and your troubles, and you're looking at it more as an opportunity to take it to the next level for them, make life easier. That's a game changer, right?
For sure.
Because to your point earlier, it's easy just to get into the routine of just putting someone a drop and sending them on their way, because there's so much glaucoma that's in this area. So I love that you're actually having this conversation and really picking their brain, but opening them up to other options and other solutions.
Absolutely.
When it comes to drops, kind of walk me through, what's your first line of defense, second line of defense, because we do have some optometry students, some new graduate students that come out of optometry school that's still trying to figure out those early stages of treatment. So I'd love for you maybe to touch on that, and then maybe we can get into some of the fun stuff as far as the surgeries and things of that nature as well.
Yeah, absolutely. I mean, I think right from the start, as much as we're dogging on drops the drops have come a long way. There's a lot of good technologies. A lot of these drops come preservative free, which is great. So these are all ways that drops have significantly improved, certainly over the last 20 years. My typical go-to, which I think, as you mentioned, prostaglandin is going to be, the initial mainstay, mostly because of the evening dosing.
Yeah.
Obviously, you're going to educate them well on the side effects, the periorbital changes for long-term use, the color changes that you're going to get. But I just find that in my patients that you're going to get the best response, you're going to get the best compliance given the nighttime dosing. Typically, if they're not, I do want to make a point that before I start, I'm at the point now where I am talking about laser in the same discussion as a prostaglandin. So
okay.
I'm not necessarily pushing one over the other, but I think given some of the recent trials, like the light trial that came out, I do think, we're very much able to offer SLT as a first-line therapy to replace the prostaglandin and try to remove some of those, complications with drops. But yeah, certainly, if they're not doing well on that nighttime dosing, or the redness is giving them trouble, I'm usually switching to a morning dose of timolol. Certainly making sure that, we're reviewing a careful medical history, making sure no COPD, and that they're tolerant of a beta blocker. I do love the combined drops, especially once you've switched them to another medication, they haven't really come down to where we want them to be. I'm going to a combined like Cosop or Comigan. I'm typically not trying to stack drops as much as I used to, though. I think at that point, if they're not responding to that first medication well, I'm saying, hey, it's early on in your disease course. It's glaucomas are only young once, I guess is the saying. So that's when I really try to introduce, laser therapy. You could say it's like, it's a light therapy that tries to restore the natural drain in your eye. And I think quickly when you mentioned that, look, there's no activity restrictions, it's a very safe procedure. And you kind of say you started them on drops, then you kind of open the door being like, hey, what challenge are you having taking the drops, or what's bothering you at the drops? Like those types of questions where you're acknowledging that there's going to be an issue. I think they're way more likely to say, hey, you know what, let's give that laser a try.
Gotcha. Now let me ask you this, because as optometrists, we practice full scope optometry, but we may get to that point where drops aren't really working. But maybe there's a time that we need to, partner with you guys a little earlier. When would you like to see that glaucoma patient come into your office? What do you think is the best contact point? Because from what I'm hearing right now is that you're actually having a conversation of SLT from the initial conversation, right? Just simply because of convenience and how effective it is. So I'm curious to know, when would you like to see your partner in crime, your optometrist, actually partner with you to take over care?
I don't know if there's one point in the journey. I think honestly, any point in the journey is valid. I think if you have a patient that is super compliant, doesn't want to rock the boat, I respect that. And I think that, if they're stable, but if, like you said, if you're not at your goal pressure, certainly everyone's target IOP is going to be different. If you're not there, I think it's always fair game to offer some type of, intervention to try to, again, avoid that medication stacking. Cause I think that's where we get into the weeds, is once you kind of burn the bridge on the ocular surface and the kind of the patient mindset of taking those drops, I think you've kind of lost an opportunity to make some long-term change in the glaucoma process. So yeah, I mean, to really answer the question, I think it's always a good question to kind of probe if a patient is willing to, would they like to remove one of their medications? And SLT is not again, like gonna get you off of 2 or 3 medications, but it can replace one. And I think for a lot of patients that can replace one, maybe 2. I think for a lot of patients that can be very meaningful, even if it's just for a few years. And I will always kind of open that conversation and say, hey, 80% of patients, we can get you down on the medication for a few years. Don't be surprised if we have to repeat that therapy 2, maybe 3 times. And it's diminishing returns. The more medications you're on, the more laser treatments you have. But I think there's always an opportunity for us to work together to get these patients in a better spot. Because again, I think it's less about the pressure, more about quality of life. And I think anytime you're sensing, hey, there's a gap in this patient's adherence, compliance, or whatnot, I think I think our that's when the teamwork really gels the best.
And I'm glad that we're having this conversation, because I do have patients that come in and they're like, oh, I got the laser, I don't need to be worried about glaucoma, I don't need to worry about drops. I'm curious to know, as an ophthalmologist, what conversation are you having on the back end with those patients? Because when they come into our office and they tell us that, of course, we got to have a different conversation with them and kind of tell them what the real deal is, right? And I know they're probably just getting a little lost in the sauce, but I want to be able to go in my practice tomorrow, and if a patient comes in and expresses that, I can back you up and make sure that we're on the same page. So I'm curious to know, what are you saying to the patients after that procedure is done?
Yeah, I try to be pretty real with the expectations. I mean, 20% of the, of those SLT patients didn't respond well, or they need a repeat treatment pretty soon, within 6 months. And it's not, I really emphasize your diagnosis is lifelong. Most patients with glaucoma progress. Sugarcoating is good. In some instances with glaucoma, it's not. And you don't want to paint the dark picture too, because we want to motivate them that, hey, you can get through this. This doesn't need to be, a huge, death sentence to enjoying your vision. As long as you show up to your appointments and get your treatment, like we're gonna keep you in a good spot. But I also don't want to paint the rosy picture that, that they're not at risk for progression. Because I mean, I think 45% of patients do progress even with therapy. So I mean, that's a coin flip, and I think it's hard to predict who is going to progress. And I think it's very important to be open and honest up front with those patients so they're not surprised. So like when they're in your office and the pressure's back up after SLT, they're not shocked when you tell them, yeah, hey, I think we need to get back on drops, because then they'll look at it as a failure when it's really, it's not. Like, it's not a failure. You know, you had a few years off of medication. Maybe your pressure's up, but it's probably not doing this throughout the day like it was when you were on medications. And so I think that's important for patients to know. And it's really interesting. A lot of the data on, benchmark data on the drop toxicity is showing that when used over 10 years, 10, 15 years, you're getting scarring of the TM, you're getting fibrosis, sclerosis, in that area of resistance. So any break we can give patients from those drops, even if they're going to end up on drops down the road, I think can be very beneficial.
I like that. I like that. So tell me this. I want to dig into this a little more. I know you mentioned that, you're educating all your patients about, SLT and opportunities and how effective it is. But is there a certain patient demographic that fits this better than other patient demographics? I see a lot of patients in my practice that are all walks of life: white, black, purple, green, yellow, right?
Yeah.
Certain patient base that I should have that conversation a little earlier with, or all the patients from the studies you've seen impacted the same with this procedure?
I mean, certainly earlier in the disease is going to be better, and certainly on your primary open angle glaucoma patients, your ocular hypertension patients. I mean, I do think, at least getting in for the evaluation. Maybe on gonioscopy, we see something that's like, hey, this is not a good fit, or a history of trauma.
Right.
Those are all instances where I'm like, yeah, you know what, probably not the best fit. But I think for the most part, if there's someone that can tolerate gonioscopy exam, they're going to tolerate SLT just fine. And I always try to make note when I do the laser procedure, patient did well with the lens, and the lens on the eye, patient did not do well. And I think if they did not do well with just that contact, patients will be out of the chair the second you put another drop in their eye, and
I'm out of here, baby.
Yeah. See you later. I mean, then that's just not a good fit. And sometimes you have to go down that hard path to figure out that information. But that's but for the most part, I do find that a far majority are a good option. But as I said, if a lot of patients hear laser and they're kind of like, no, I want to stick with drops. And hey, that's totally cool. And those, I find, I mean, this is totally anecdotal, those are some of the most compliant patients as well, that have like such a strong feeling, and they know like if they're compliant or not for the most part when they make those decisions.
But are you seeing that this procedure is more effective in Black patients, Hispanic patients, Caucasian patients?
Good question.
Women.
Yeah.
How does that play into the role?
Yeah, to be honest, I haven't found. I'm sure there is data on that. I haven't found which demographic it is a better fit for. Certainly, the more pigmented TM. So certainly, if African American patients have more densely pigmented TMs, that's going to give you a better response with the laser. Okay. But I'm not specifically saying male, female, African American, Caucasian, Hispanic to make those decisions.
Gotcha. So okay, we've touched on drops, and we've touched on SLT. Something that I feel has been pretty hot over the last probably decade, 5 years to a decade, is truly Migs. So I'd love for us to really break that down, because I feel like that is a more difficult conversation to have with our patients when we're saying we're going to send them to a glaucoma specialist.
Right.
How should we frame that conversation? And let's even take it a step back before we even get there. What is Migs? If you don't mind breaking that down, and then let's talk about how we should tackle that patient journey and have that conversation with them before we refer them out to you.
Yeah, so microinvasive glaucoma surgery is a form of glaucoma surgery that's going to essentially bypass the trabecular meshwork, whether that be in removing tissue, removing resistance, whether that be in stenting. It's going to be an angle-based procedure. So that in its simplest form is microinvasive glaucoma surgery. It's typically going to be paired at the time of cataract surgery. There is a camp of what's called standalone Migs that's approved with insurance without cataract surgery, but typically it's going to be at the same time as cataract surgery.
Okay.
And so, really where that conversation comes up in relation to cataract surgery, not to simplify it too much, but it's really how well controlled is this patient from a glaucoma standpoint? Because if they're not well controlled from a glaucoma standpoint, I think your benchmark for success with Migs is harder to hit.
Okay.
Because they may need a little bit extra, or they may need to say, hey, this isn't going to replace any drops. Your drops are probably going to stay the same. Maybe this will help us get those extra 3 or 4 points to get you there, to get you to your goal pressure. But that's really the biggest thing, is I think setting expectations. And I think if their glaucoma is well controlled, then we can start focusing more on, hey, this is the cataract surgery with the same refractive expectations that our cataract surgery patients have, and we can combine Migs, as an adjunct to that.
Gotcha. Now, are you, if you have a patient that comes in and they have a NS of 1, NS of 2, and they have glaucoma that's not truly controlled, are you pulling the trigger to do the Migs and have the cataract extracted? Like, how do you know when it's that time to set that patient up? How does that work?
It's certainly a delicate border that you're delicate line you're walking with that. I if it's not visually significant cataract, I'm not necessarily signing them up for cataract surgery.
Gotcha.
I'm still kind of waiting for some night symptoms. I think this is a unique opportunity, certainly in your angle closure patients, your hyperopes that are, you can pretty much treat their narrow angle suspect or narrow angle closure by removing the cataract. Now, that's a conversation I'm having probably a little bit sooner before it becomes a little bit more visually significant. But your open angle glaucoma patients, I am still kind of waiting until they're ready for cataract surgery, and certainly then we have work to do on the glaucoma until that point. And what's nice with those hyperopic patients is they have a great visual outcome, given the reduction of the hyperopic correction after cataract surgery. It's a tougher argument to make, I think, and if it's not yet visually significant with your POAG patient when considering Migs. So that is where standalone is nice to have. There are a couple standalone options that are very efficacious. If you're not in a good spot drop wise, on the forefront is sustained medication, intracameral release, with what's currently being offered with latanoprost. And then, hopefully at that time you can get yourself some time for that cataract to get visually significant.
I love it. So it seems like you really have, a good table or a good set of options to tackle any patient that walks through your doors. And it sounds like, when we're having a conversation as optometrists, we can really set them up for success when they come to see you, by just understanding, basic or broad knowledge of what drops can do, what SLT can do, what Migs can do. What does that procedure look like? Because at the end of the day, teamwork makes the dream work. If we can partner together, that patient journey, that transfer of trust from the optometrist to the ophthalmologist can be life-changing, right?
Absolutely.
And with glaucoma, the way that it's going and the stats that you mentioned earlier, we got to do something about it.
We do.
Because people are truly losing vision. I am blown away by how many patients walk in my door and they have severe glaucoma.
Yeah.
And these aren't
crazy,
just somebody just randomly off the street. These are people that, best of shape, best of fit. They say they get their physicals year in and year out, but for some reason they don't pay attention to their eyes. And at that point, it's a wrap. There's not much you can do at that point.
Yeah, you're behind the 8 ball before you even met them, and it's really sad because as much as we're talking about advances in treatments, we've come such a long way. Diagnostics, catching, prevention, we're kind of lagging behind. Just getting that net of patients, and there's so many patients walking around with undiagnosed glaucoma. As you said, it's very unfortunate.
So let's kind of talk about the future of eye care, the future of glaucoma. Where do you see this specialty 5 years from now? Because I know, at least in optometry, just hell, even in eye care, the drops that are out for dry eyes, the medications for geographic atrophy, it seems like this is the best time to be in eye care because of all the advancements and innovation that's out there. So I'm curious to know, what are your thoughts 5 years out from now?
Yeah, totally. And I feel the same way about glaucoma, man. Let's see. I don't think we're managing pressure well at night. And I think, I think there's got to be something coming down in the pipeline that's going to be able to not only monitor pressure at night, but hopefully lower pressure at nighttime,
Okay.
whether that's in the form of goggles or some device that
Mm.
can help at nighttime. Because I really feel like we're not managing patients' peaks outside the office well. So I'm kind of going through like, what are some of our weaknesses now? Where do I think, we have some room for improvement? I'm really hoping that in the realm of neuroprotection, we can get some advance there, because it's nice that we can monitor and change IOP. I think retinal ganglion cell death is something that is very well studied. Unfortunately, not any great options at the moment, but that's, I think, a pretty exciting part of the field moving forward. I think even something that's currently available now is pretty exciting. It's like home eye care monitoring. Like you can literally, sign a patient up for home eye care, see if they're spiking at home, and then that can help really drive your treatment. I mean, if they're spiking at home, like, you may not need to be as invasive as if they're progressing with a low pressure that's not spiking. And so it's cool how you can make your decisions just based off of new technology that's coming. I think with AI and some of the virtual reality, I think we're going to be able to give patients quicker visual field tests, more reliable. And again, these are all very optimistic hopes, but it's very exciting for the field of glaucoma. I think for earlier diagnosis, better detection of progression, and certainly hopefully safer treatments.
And something that I would love to see is technology that actually simulates what will happen if you don't take your drops.
Totally.
Right? So imagine showing a patient that if you don't do this drop every night, after year 1, this is how much of your visual field has been removed. Year 5, this is how much has been removed. Year 10, how much has been removed.
And it's like showing them the black lung. Like, we need something in the field of glaucoma that does the same thing. I agree.
And I'm not trying to scare patients, but I am trying to
totally.
scare patients because I want to know what's cooking up, right? So, I'm not a big glaucoma guy. I see a lot of glaucoma. I partner with, my colleagues or you guys. And I just think that, as a whole, we have to do better with creating more awareness of it. People don't know that they have it. It's that silent killer. And it's just one of those things that I just hate to break down news to folks that you have no more peripheral vision left. Your vision is gone. There's nothing that we can do about it. So I think folks like you, man, that are innovative, that sit down and really have that conversation with the patients, that really give them their options, that really educate them from top to bottom what this will look like. But most importantly, you're all about improving that quality of life. And I think as eye care professionals, we got to really hone in on that and not look at a patient as a number, but look at as a patient as someone that we can help take their life to the next level. Because at the end of the day, your vision is the most precious sense that we have, right? And if you're not able to see and you're used to seeing, that's going to be difficult to bounce back, especially when it comes to work setting, especially with those precious moments of seeing your baby's face or your significant others, or missing that ball game, or being able to drive. So it's very important that we, as eye care professionals, optometrists and ophthalmologists, continue this partnership, but also, most importantly, elevate eye care and take it to the next level.
Absolutely, man. It's everything. It's everything.
I love it. So one thing I always like to ask all my guests before we leave the show is, when it's your turn to retire your phoropter, when it's your turn, I guess, to put the SLT laser down, what do you want to be known for, Dr. Barsam?
Yeah, I'd really like to be known for someone that just goes, above and beyond for their patients. That's always, there for them to try to do the best treatments for them, and just be a kind, considerate doctor. I mean, I feel like a lot of our patients, they can't control the disease process they have, and they need someone to help guide them through. And if I can do that, I'll say, it was a great career.
I love it. I love it. And for those that may be local in my backyard in North Carolina, the Raleigh-Durham area, if they're looking for someone to send their glaucoma patients to, what's the best way for them to connect with you?
Yeah, absolutely. So, our practice, North Carolina Eye, Nose, and Throat, we can certainly help get you a visit. And, I'm on, social media, and my email is certainly available, for after this visit.
Awesome. I love it, man. Well, thanks so much for hanging out with me. It's always great to have a local celebrity be a part of the podcast.
Oh, you're too kind. Yeah, you're too kind.
Continue the great work.
No celebrity here.
Continue the great work. Continue making a change. And most importantly, thank you for taking care of all of our patients in the Triangle. And for all of those that are listening to this podcast, Thanks for tuning in. Stay healthy, stay positive, stay blessed, and until next time, peace. Hey, family, if you enjoyed this full podcast, don't miss out on more engaging content. Check out the next episode right here. And for the latest updates, hit that subscribe button and ring the notification bell. Your support means the world to us. Catch us in the next episode. Peace.